so much for coming to the webinar this afternoon, and thank you and welcome to everyone who joined us online. This afternoon we'd like to have Christina Riley join. So Christina works with CERI in a collaborator, our big science, big data, and I thought it would be really interesting for Christina to share some of the work she's been doing. I think relevant to many of the people that are here. So we are delighted that Christina to join us today. Okay, right. So I would like to introduce Christina. So she is the director and portfolio lead at Akros, and Akros is a digital health firm that works to establish data-driven systems to improve the health and well-being of communities. So Christina leads the design, management, research, and technical implementation programs that utilize geospatial data for targeted public health intervention, deployment, and monitoring. So Christina has conducted malaria operational research and programmatic implementation across the African continent and in South Asia for more than 12 years. So today, Christina is going to talk about empowering health with genomics and geospatial insights. Better to talk about. Okay, so hand over to you. Thanks, Christina.
Great, thank you, Cheryl. Can you all hear me okay? Wonderful. Good afternoon, and thank you so much to CERI and Stellenbosch University for having me speak today. As Cheryl mentioned, my name is Christina Riley. I'm a director and portfolio lead at Akros. Akros is an industry partner to CERI and to the larger DSI Africa consortium that I'll be speaking about in just a moment. And we're based in Zambia, but do work all over the continent. What I'll be speaking about today primarily is our Reveal platform. It's a digital geospatial platform, open source platform that we've developed with our partners for about over the past 10 years with the purpose of being able to bring data to bear and use data for decision making in terms of public health intervention planning, delivery, and monitoring. And so we've been doing that for, I would say, the past 8 to 10 years. And more recently, we've pivoted the platform to also be able to do genomic surveillance on the infectious disease side. So as I get started today, you can see that on the slide, there are a number of logos for programs and partners. So I want to start with speaking about kind of the ecosystem that we're operating in. So as part of this and part of our partnership with our colleagues here at CERI, we're part of this DSI Africa program, which is a U.S. National Institute for Health funded program that works to harness data streams and data-driven technologies across the continent and utilize those for public health interventions and public health preparedness and response. So as part of DSI Africa, I think there's 7 different research hubs. There's a number of training hubs and other projects that are looking at the ethical, legal, and social implications of all of this work that we're doing. And so our role as Akros is one of the industry partners. And we're operating through the Inform Africa Research Hub, which CERI is a part of. The purpose of the Inform Africa Research Hub initially was to start looking at COVID-19 transmission dynamics, HIV transmission dynamics across a variety of projects and partners. To understand what those interactions look like and also how that can inform public health preparedness and response moving forward. So we're here again working with CERI on that, Institute for Human Virology of Nigeria that leads the research hub, as well as CAPRISA, and then some partners in the US, Villanova University and University of Maryland. The second DSI Africa project that we as Akros are a part of with IHVN I'll also be touching on today. That is the GDRS project. That's based currently in Ghana. And that's where we're pivoting this Reveal platform to do genomic surveillance for anti-malarial drug resistance. So as I get started today talking about what we do generally with Reveal, and then specifically under Inform and under GDRS, these are just several different use cases that Reveal can be used for. But there's a number of things for which it can be used that we would like to use it in the future. So please keep that in mind as I go forward. I'll get started with a little bit more background on Akros and the Reveal platform, so you have an idea of what it is and how it came to be, and then go into a malaria case study from a few years ago. And then we'll talk more about Reveal specifically for genomic surveillance and for public health preparedness under DSI. And if I am going too quickly, please let me know. So Akros we're a very small NGO based in Zambia, woman-owned. We've been around for about 15 years. We have a number of projects and partnerships across the African continent, as well as Southeast Asia. Our mission is really to establish data-driven systems to improve the health and well-being of various communities. And we do this really from a digital health lens and a geospatial lens, and getting the power of that technology and that information into the hands of government officials, implementing partners and decision makers in order to do more targeted delivery of public interventions. We also have a particular focus on bringing health in a precise way to last mile communities. So I'll really start there in terms of what those last mile communities need and how we aim to reach them. Back in about 2014, 2015, we're working in Zambia. And one of the biggest problems that our implementing partners in the government had was in trying to identify where the population was in these rural areas, how it was distributed, and what that denominator was in order to make sure that you are truly reaching every person. And so in order to start solving this problem, we began using satellite imagery and would enumerate, essentially go over that satellite imagery, review it, begin enumerating households and communities. And around this time, as we began doing this, we realized that it was often only maybe 60 to 70% of the population or so that had been accurately quantified through perhaps the census or through village head counts, et cetera, but you still had a good 30 to 40% that was missing. And so through the use of these maps, we were able to start doing appropriate planning to reach people, make sure that we were allocating resources appropriately and resourcing up in cases where people were missed. And this is kind of what led us to digitize those maps and create Reveal. And since then, we've also worked to operationalize spatial risk models. We're starting to move into some predictive risk mapping with all of the data streams that you're then able to layer on top of that. And then through all of that information, build that into the Reveal platform for more precise and real-time delivery of these different interventions. So just to illustrate this point a little bit more specifically, this is what we refer to as the denominator challenge. In this example, you're looking at a village of households, and everything in yellow, you can see there's about 90 households there. And the intervention example that we'll use is for indoor residual spray or for mass drug administration, both of which are very important in terms of having individual level delivery of those. But also there's a certain level of community level protection that needs to get conferred. So you need to also reach a threshold number of people or households with these different interventions. So in this example, the team is able to reach 80 of these 90 households that they've found on the ground. This is without any type of map or digital tool. However, all of the houses in gray that you see here are those that were not known, and those that were completely missed for this intervention. And so your true coverage, instead of being about 89%, is actually 57%. And that's well below a threshold for community level protection, as well as all of those individuals that are missing out on whatever that intervention happens to be. So this is where, as part of this problem, you have all of these big public health programs that are reporting, between 85, 95% coverage, when in actuality it's much, much lower. And that's one of the main reasons why interventions aren't as effective as they can be. So from about 2015, 2016, especially within Zambia, the use of maps in order to do planning and public health service delivery became very important, and that's since kind of extended across much of the continent. So this is just an example showing once you do start using mapping for public health intervention service delivery, you can also begin using geospatial information to do more targeted and precise planning. So this is an example of an area where we had only a certain number of vector control supplies. So either indoor residual spray or bed net distribution. You couldn't do universal coverage of both. You just didn't have enough. And so then you had to be strategic around what communities are going to receive IRS versus which are going to receive bed nets. And for those that are familiar with this, bed nets can last for between 3 and 5 years in most cases. And so it makes more sense to prioritize communities that are a bit further away for that intervention so that you're not always having to go back and do this year upon year. Whereas population centers that are easily accessible were more appropriate to receive IRS. And so this is an example of where a team in Zambia went through, they prioritized different areas, and they were able to achieve universal coverage of vector control while still allocating resources appropriately. These two examples are showing, and this is all pre-reveal, where we've been able to use maps and digital information as well to improve public health service delivery. So on the left-hand side, you have a map of Senegal showing health facility vaccination data against the estimated population. So you know which areas need to be prioritized for additional vaccination. On the other side, we have travel distance to those vaccination centers. So you can think through how much time and how many people do we need in order to deliver these, to deliver vaccination, so you can appropriately plan for that intervention as well. So one last example, this is an area in Yemen where we were looking at onchocerciasis, and so that is transmitted by the Somalian black fly. Okay. And so naturally, in order to do an appropriate targeting strategy for mass drug administration to protect the population, we needed to map where the Somalian habitat was against where the human population was, and only target human populations that have Somalian habitat, which is turbid waters, usually in these valleys, and then target from there in order to deliver mass drug administration. From here, you can see that you can create a transmission model for this, and then you employ that on the ground as part of the mass drug administration campaign. You're also able to deploy vector surveys and do field verification. Is the black fly in fact where we think it was going to be based on different type of geospatial information? Yes and no in different areas, and then that improves both your targeting and your coverage, but also these transmission models in the future. So thinking through all of these examples, all of this different information, this is where Reveal has kind of been born from. And we pull in all of the geospatial information, your various data layers, use it for additional data collection, both for service delivery, but also field verification of the various information that we have. And then you're able to continue refining that and refining your targeting strategies and your ability to deliver in a really precise manner. So with the Reveal platform, there are three main components to it. The first is your visualization and planning piece, which is where all of that geospatial information is pulled in. From here, you're able to map various data streams and then begin targeting and assigning areas for that public health campaign, both in terms of the locations that you've identified, as well as assigning teams to those locations to carry out those interventions. From there, once those plans are activated, that information then gets sent down to a mobile application, so on a phone or a tablet. And your teams in the field are able to go to the areas they've been assigned. They can navigate to those areas similar to how you'd use Google Map on your phone. And then you can begin delivering that public health intervention. And so as you deliver that intervention, whether it's at the household level or the individual level, the information on your tablet updates. So a house goes from, say, yellow, not visited, to green. You move through your area, make sure that you've achieved your coverage targets. And then at the end of the day, that information, that data then syncs up to the web platform into that third section for monitoring and response by supervisors, as well as by higher level decision makers within the government and your implementing partners. So going through this in a bit more detail, and I know that some of this information is fairly simple, especially for this audience, but it's incredible how having access to this information, particularly by government stakeholders and people on the ground, how much it really transforms their ability to deliver these interventions in real time and achieve really high coverage. So this is just an example showing you how we pull this geospatial information into the platform. So on the right-hand side, actually with the yellow structures and the yellow boundary that's been drawn, this is where we started originally, where we would have teams of enumerators sitting kind of in Google Map or JOSM, and they're going through drawing these structures individually, and then that data is getting pulled into the Reveal platform. Fast forward a bit, and now we're able to use various remote sensing algorithms through Grid 3 that run over Maxaracopia building footprints. And this has become a much faster, more automated process where we're able to pull this information in. We can create these operational areas, which is the white boundary that you see, based on various settlement densities for the given intervention. For example, for IRS, you want to have areas that are maybe between 500 and 800 structures or so, versus for an intervention such as a mass drug administration, you need smaller operational areas for those community health volunteers and community health workers to get to. So we're able to do all of this fairly quickly now, pull all of that data into that first part of the web platform. And then you're ready for the digital planning piece. So at this point, this is where data sets such as those that are generated through the Inform Research Hub can be pulled into the platform. So one example that we'll look at later is on Place Resilience Index, which is similar to social vulnerability, and being able to look at different areas that are more vulnerable or more resilient and prioritize those for interventions. You can then layer on different disease risk layers, climate information, rainfall, all different sorts of data that might be relevant. Once you have all of that data layered in, you're able to start targeting your areas and then assigning teams and resources to those given areas and making decisions based on what resources you have access to or the timing that you have available. So this is just another example in Nigeria where we loaded in, I believe this was a COVID-19 vaccination data set. And you can see what areas have achieved higher coverage and which are still remaining that need to be prioritized. And then based on your information, such as population, disease risk, et cetera, you can begin prioritizing all of that. From there, once you select your areas for the campaign, you then are able to assign teams to each of those areas, activate the campaign, and then begin collecting data on your mobile client. So this is an example in Zambia where they're doing a mass drug administration campaign. In the middle, you can see the blue arrow is essentially location, and you're able to move through this area. So all of the houses in yellow have yet to be visited, those in green have. Go through, begin delivering your intervention, collect data on your household, on your individuals, and then you're able to monitor your coverage based on these on-app indicators in the field. All of this does work offline, which is particularly important in areas where you don't have connectivity. There's a Bluetooth feature on the application that allows you to share data between your different data collectors or community health volunteers, so that you're able to stay in the field for a while, monitor that intervention coverage, make sure you're reaching those thresholds. A mass drug administration campaign, and this could be in the context of malaria, or it could be other infectious diseases such as onchocerciasis. It could even be, you can think about it in terms of vaccination as well, is when you go house to house to deliver drugs to individuals. And so the application is configured both for individual level drug distribution, as well as distribution of, say, bed nets or indoor residual spray at a structure level. We can also do point-based distribution. It just depends on what the needs of the intervention are. Thanks, Julio. So from here, actually, see if this plays. This is an example of a worker that's at a household. They're moving through, they go to this household. As soon as they collect data on it on the tablet, it turns green. One of the red ones might be a structure that now needs to be revisited because there was a refusal, or there was perhaps a referral to the health facility. So there's some reason for follow-up at that structure. All of this data at the end of the day or the end of several days, once teams have moved through an area, then, oops, here we go. Then syncs up to these dashboards. So you can view these in a tabular way, as well as in a map view. And this gives you, all of this is configurable as well, gives you all of your indicators. So this is where supervisors and government officials will go in, monitor how well a team is doing in a particular area. You can drill down all the way from higher levels of the hierarchy, say, South Africa to the Western Cape, down into the district level, all the way down into certain villages here, and just have an idea. This gives you an example of how well the team is performing. So in this example, there's a lot of yellow and green throughout this area. They've gotten to, I think it's about 50%. But you can see that because there's yellow and green throughout here, they haven't necessarily done a good job of moving through this area strategically. And so they'll need to go back and visit all these yellow structures, and it's going to take a bit longer. Versus this next area, this is a team that has been through this area much more strategically. Most of the green down here is covered, and then you've just got small pockets of yellow. So at a very practical, from a very practical level, this helps supervisors with their team, giving them advice on how to move through, make sure that they're doing things strategically, and then they're able to achieve those much higher levels of coverage in a much faster manner. So it's important at both that low field level as well as quite a high level for decision makers in looking at how much time and resources they have left for a campaign, other areas that can potentially be prioritized if they still have resources and time left, in order to make sure that you're really using your resources efficiently and achieving the coverage that you need to. So that section is a bit about reveal where we've come from. This I want to show, I'm going to talk more about an indoor residual spray example in Zambia, and how those coverage levels have dramatically increased based on the utilization of both geospatial information and mapping, and particularly the use of reveal. So this is a district in northern Zambia called Nchilenge. This district is notorious for extremely high malaria burden, very stubbornly high. Every intervention in the malaria toolkit has been thrown at it: indoor residual spray, bed net distribution, mass drug administration, additional case management activities, additional vector control activities, and it still remains at about 50%. It's a very swampy area. It's also close to the border with DRC, and so there's a lot of immigration into this area, and there's internally displaced populations here. So all of this really complicates the ability to deliver services and understand what your population is. So in this example, this is a map in early 2019, pre-campaign. Everything in yellow are all of the villages and households that are eligible and need to receive indoor residual spray, or I should say some type of vector control intervention, whether it's indoor residual spray or bed net distribution. This map shows you at the end of the campaign what the teams have been able to achieve. So everything in green has received the indoor residual spray intervention. You also have a number of communities here in black that are marked as ineligible for various reasons. So in this context, these might be structures that aren't made of sprayable material or are too close to, say, the lakeside, and there's ecological reasons why you can't deliver that intervention. And then communities in blue are those that haven't been visited at all. There's no field verified information there. And then there's a bit of red sprinkled throughout where those are refusals. So in 2019, when this was the first year we used Reveal in this area to deliver the intervention, the found coverage by the team, which means that people actually went to those houses to do some sort of field verification on eligibility and whether or not they were sprayed. There about 74% of the entire community had actually been visited. And then of that, only 61% of the full community had actually been sprayed. In the context of malaria and indoor residual spray, your threshold for community level protection is somewhere between 85 and 90%. So this means that none of these communities are adequately protected. You do have some individuals that are appropriately protected. In reviewing this information after 2019 with the funder and with the government and the implementing partner, we came to realize that all of these areas here in blue in 2019 had never been visited. It had been assumed that there weren't people living there and that it wasn't important to get there. So they didn't have the resources. They didn't send people to do that. So at that point, at the end of 2019, it was decided with this really high malaria burden, this is potentially one of the massive reasons why it continues to be high, because you're not protecting all of the people that live there. So in 2020, they increased the number of community health workers, the number or the amount of indoor residual spray that was procured for this area. And we also combined it with a bed net distribution campaign. And so the findings from this, and I'm kind of giving away the story, but we went from 74% found coverage to over 96%. So 96% of all of the structures were visited. And then your spray progress increased to 90%. And this is still without the bed net distribution campaign. This is, again, you've seen this image before. This is an example of how we then looked at areas that needed IRS versus ITNs. And we did this through the tool. So certain teams received a plan for IRS and went to those areas. Others received a bed net distribution plan on their tablet and then would have gone to those areas as well. And so we're able to track the differences between where people are for IRS versus ITNs. This was, so in these areas that you can see, there's lots of black and yellow. These were the specific areas that then were eligible for the bed net distribution campaign. So the team went through, they delivered IRS, and then there was a follow-up campaign done specifically for the bednet distribution. Once all of that data had been collected, and this is now delineated by zone as well as health facility catchment area, so that means that you're looking at things at quite a granular level, community by community. We then calculated the IRS coverage and the bednet distribution coverage, and we still had some areas here in red that had less than 70% co-deployment between the two. So utilizing all the information that had been collected from the tool, we were then able to calculate the number of bed nets needed to fill that gap, and then sent the teams through to do another gap filling campaign in which they were able to achieve 100% vector control, so either IRS or ITNs, across this area. So you can see, I think, from this story, the importance of both the information for where all of the population is, the eligibility based on structure materials, which also can be found out through those remote sensing algorithms. You can tell by the roofing structure and roofing materials, as well as the proximity to water bodies, because those areas would also need bed nets over IRS. So pulling all of that information together, you're able to hit 100% vector control coverage. You never would have been able to do that before. So now we get to the point where with 2020, 2021, and this is the start of the DSI Africa Consortium. So up until this point, Reveal has essentially been built for campaign planning, campaign distribution. But the tool itself has so much capability in terms of being now able to pull in all these new data sets, various data streams across the continent, different partners. And so that's where we've entered into with Inform and with GDRS. So I think, as I mentioned before, Akros, sitting under Inform, is the cross-cutting industry partner. So we're really sitting at the nexus of academia and then government and implementing partners, those stakeholders, to try to bring all of the data and the rich data that's being produced through our academic partners and put that in the hands of government officials and others that are working on the ground in order to make their campaigns more efficient. So we took Reveal, we built out the planning module further. We've also started working from those data outputs to create different types of spatial models and do predictive risk mapping. And start to generate maps of vulnerability and risk transmission. So this is an example in Nigeria where in the pink here you have COVID-19 seroprevalence data. And then this has now been overlaid with COVID social vulnerability data. So you're able to look at the two and identify what areas in the future you might want to visit for vaccination first. Because of that social vulnerability, we can then layer on current vaccination data, other vulnerability information such as age or say COPD prevalence, things like that. And then from there, that's where you can then operationalize spatial intelligence to drive intervention and policy planning. So going now, we're pivoting from kind of this campaign planning idea into the surveillance side of things. So under the GDRS project, which is run by Akros, IHVN in Nigeria, and then WACBIP in Ghana, which is the West African Center for Cell Biology and Infectious Pathogens. We've identified an area in the Upper East region of Ghana where they have quite a strong surveillance system for both parasitological surveillance for antimalarial drug resistance, as well as some entomological drug resistance. And so we've taken the network that they have, and now we're utilizing Reveal to begin collecting data on passive case detection, confirm those cases geographically in the field at a very granular level, so that you can begin to track how the genomics of your parasitological resistance changes. And there's a lot of questions here. Is that important to know at that granular geospatial level or not? It might be, it might not. The one thing that it does allow us to do, however, is you can now see where you have resistance starting to pop up. And then you can begin to have those conversations at a higher level with experts and with government stakeholders around what to do as that resistance information pops up on the dashboards. Do we need to think through our first line and second line treatments? What access to medicines do we have available in these different areas? And what do we need to do in order to mitigate the spread of that resistance? Even at a simpler level, you're able to see as malaria cases come in, malaria hotspots and outbreaks pop up. And now even for, implementing a mass drug administration campaign or indoor residual spray, you're able to implement those interventions in real time. So just in more detail, this is what the current model looks like. You have in your green squares, your community level laboratories, and then in Akros, your next gen sequencing lab. Right now, or prior to reveal, I should say, the most granular level of geospatial information you have is usually at the district level based on where that community laboratory is. Whereas with reveal, now that we're confirming these cases at a household level in the field, you're able to look at that at that level, all the way down at the household. As this information comes in, we're also then able to layer on additional data streams. So this could be in the form of historic malaria risk, vector abundance, climate data, so that you can start doing predictive risk mapping. And as the information comes in, you can respond appropriately, whether that's in the form of reviewing policies on your first and second line treatment, or it's just in implementing a mass drug administration campaign because you've got a malaria hotspot that pops up. So, and this can be, we're currently using it for anti-malarial drug resistance, but it can be used for all different sorts of genomic surveillance. I think one question that likely comes to mind at this point is around data privacy and concerns such as that. So I'll speak more about that at the end, but that's something to keep in mind. So I think just to give you an example of what this looks like on the tool, as in terms of the workflow for this anti-malarial drug resistance, you first have a case come into the health facility. They confirm it as malaria. It goes for parasitology. A dried blood spot is taken for your genomic information. And then the field supervisor gets an email stating that they now need to go out to the field to confirm the index case and then do reactive case detection in that area to potentially identify other malaria cases. As they go out to the field, the specific household that's been identified for that index case is in blue. As they go through and collect data, they're able to confirm that that is the index case, or if it's not, identify another structure for it. And then that information turns that house purple, and then they go through in these other yellow structures for people that are living there and do all of the reactive case detection. One thing to keep in mind here is that because of the way this data is being collected in real time, over time, we're also able to see how many other cases there are in these areas. And so if we need to, we can expand or contract this radius of selection for doing this reactive case detection and testing and treatment to make sure that you're driving impact there. Potentially in higher seasonality for malaria, you might need to expand that radius and do further testing and treatment versus in a lower risk time or season. It could be smaller, but that's, again, another open question that we have that we're trying to understand. So I think at this point, I'd like to do just a very quick demo of the planning part of Reveal to show you under Inform some of the various data layers that we've loaded in and thinking through for different types of campaigns or pandemic questions, how you can look at that different data and then operationalize it for a campaign. Okay, we'll see if I can do this while I'm speaking into the microphone. So this is your Reveal landing page. I will log in with my username and password. One thing to mention here, for the tool, naturally everything's encrypted, it's password protected. We have various levels of users and role-based access controls. So for someone that's a lower level user, such as a field worker or a field supervisor, when they log in, they're not necessarily able to see all of this information. They're just able to see the reporting page. Versus I have access to the planning page, reporting, as well as the admin module. So specifically within the admin module, this is where you're able to upload different data sets. So if you have, say, COVID-19 vaccination data set, or maybe you're working with a genomics data set that's showing you drug resistance, for malaria, for another disease. It could be something that you yourself are working on and you're not ready to share with others. As long as you have the correct user permissions and role-based access controls, you can upload your data and start exploring it within the simulation page. And not have to worry that anyone ever is going to gain access to it until you decide to provide access to those individuals or to your team, to your research hub, whatever that might be. There are a few public access data sets that we have loaded, but very few, because most of the time you do just want to work within your own data or work with your data within your own team. So briefly, just to go over to the planning, because I'm aware of time. We'll start with the simulation page. So this is where you'll find your specific locational hierarchy that you're working with. So for the purposes of today, we've got Nigeria loaded. And then as this zooms in, I already have some data sets that have been preloaded against Nigeria. So at the moment, we have a dummy data set for COVID-19 vaccination. We've got our COVID-19 social vulnerability index. And then as a component of that SVI measure, there's an elderly proportion. So if, for example, we've now had several waves of COVID and we've got a variant of concern out there, you've started sequencing it, and you want to think, or you need to think through, as that variant of concern enters into Nigeria, what areas are most at risk? Where do you need to go in order to start delivering an intervention? Whether that might be messaging, shutting down, say, or implementing lockdown procedures, or it could be in terms of a vaccination campaign. Where do you want to prioritize? So if I turn off, let's see, we'll turn these off so you can just see your social vulnerability first. So we're looking at this currently at the state level, but this data set has actually been loaded at the next level down, which is the LGA. So I just need to go up here to display data sets by parent level. Admin 2, which is the LGA, and then this map will update with those values for LGA, which is similar to a district here in South Africa. So this is giving you an idea of what areas are most socially vulnerable to COVID-19. In this particular example, however, maybe we're already thinking about our ports of entry and our international ports of entry. So the places that we're most concerned about are potentially Abuja and Lagos, which both have international airports. And so perhaps Lagos is the place that has the most transport and spatial mobility. And so we want to focus on Lagos and start looking at social vulnerability there. So I'll go up here to Nigeria. Select Lagos, this pulls me in. And now I can look at this social vulnerability information by LGA. So I'm getting information on the population, what the index looks like compared to other LGAs in the area. So at this point, I know that I have enough vaccination doses, but I wanted to prioritize it based on a timeline. So based on this information, both Ibeju-Lekki and Amuwo-Odofin have the highest SVI. So those are the areas that I would like to prioritize first. So I can select this, add to campaign. I think we already have Amuwo-Odofin added to the campaign. And then in this legend area, I'm able to toggle on the areas that have been assigned. And then I can go through and start assigning teams to these areas. And so I would do that in a different place here under campaign management. I do want to be cognizant of time. So I think we'll stop here. I think that gives you an idea of how you add your areas, how you add your teams, and then you can immediately activate that campaign. Someone then logs in on your mobile client or on a tablet. They can start delivering vaccination doses to these communities, to whichever ones they've been assigned. So I think at that, the last thing I will say is just kind of an overview of where we are with this. We have done stakeholder trainings in Nigeria and virtually recently. We're looking to collaborate with different partners, in terms of getting these informed data sets, the ones that are appropriate to get into the hands of decision makers, government, whomever, but also getting people to utilize the tool, whether it's for campaign planning, for genomic surveillance, and just generally for pandemic response. So I'd like to thank our collaborators, first at WACBIP and IHBN on the GDRS side, and then a number of people, including Tulio and Cheryl, here on the Inform Africa side at CERI, IHBN, University of Maryland, Villanova, Caprice, and Stellenbosch. So thank you.
Thanks so much. Now it's time for questions. So I'm sure that has stimulated lots of ideas for future and current projects. So Mariah's up first.
Very interesting talk. I have no background in any kind of big data things. So I'm kind of wondering, I have a clinical background. And if you wanted to link like clinical data sets to this, what kind of, do you need then like basically an address of a patient, or how could you link, like, for example, if you have a cohort of resistant TB cases here, do you need then like that address information, or how do you link that to these kind of maps to do your outbreak response?
Okay, can you hear me now? Great. That's an excellent question. So there's, I would say, two main parts to that answer. On the geospatial side, in terms of what information is needed for that, it depends. It would be great to have an address, but I think, as I was alluding to earlier, particularly for TB, HIV, for diseases that are quite sensitive, that information isn't appropriate. And so in these cases, typically what we would do is some level of geomasking, and that can be done a few different ways. You can do it if you have like a cohort or a cluster, based on aggregation to maybe a ward level, or to enumeration areas, depending on what you have available in the country and how granular that is, without getting all the way down to a GPS point or an address. So some of it's aggregation based. Some of it you could, we've also done scrambling of GPS points in an area, so an idea in terms of how things are clustered, but not actually looking at them on a map, or it's been scrambled enough that it can be on a map, but you're still looking at it within a specific zone. Third option that we've looked at but haven't yet done is, which is a bit similar to the first, is rasterizing that data, so you have a specific value for that particular square. You would also need, many cases, if you're looking at this, what your intervention is, a way to quantify that in terms of a denominator. Most of the data that we use within the system currently, while we can use this data, is usually, we usually use a population level denominator. The prevalence is instead.
And another question would be, like, how real time is your mapping, like, on the satellite data? Because for many infectious diseases, migrant populations that are moving around are important, and how well do you capture that with your mapping?
So it depends on how we're utilizing the tool. If it's real time in terms of the delivery of intervention. So as long as your community workers are uploading data today, then you're going to be able to see it within, say, the 15 minutes of upload. So in that sense, real time. On the surveillance side, usually that's taking time for the data it needs to do, say, the capital to go through genomic sequencing, all of that processing. And so that depends on that process. That's usually more of a month. In terms of looking at internally displaced population, depends on how you're collecting, viewing that data. If you're using satellite imagery to try to find IDP, then that depends on how recent the satellite imagery is and your access to that satellite image. So that's a big question. So there's different sources of satellite imagery. The satellite imagery that we stream generally, it doesn't need to be for interventions. It's usually somewhere between 6 months and 2 years where we're getting our satellite imagery from. If you are a specific program that is able to get access to up-to-date satellite imagery through agreements with Landsat or MAC, then it can be more up to date, but that is really expensive, or you'd need agreements either through government or.
Just to add to that discussion, well, you mentioned 6 months to 2 years for satellite imagery. Does it ever happen that your field worker will pass a structure that is not on their tablet? What do they do then? Do they have to come back a couple of days later or wait for the satellite imagery to upload? I just found that very interesting.
Yeah, that's a great question. So no, they don't need to do that. You're able to add structures immediately on tablet, and then usually at the end of a campaign, you can reconcile that information, create a polygon out of it, that sort of thing. And I say 6 months to 2 years. That's just typically what we use. That's what we have free access to. If a campaign or a program needs more up-to-date satellite imagery, then you can have those discussions. But for a simple campaign, you're just able to add those structures or mark them as ineligible if the structure no longer exists.
It's fantastic. such wonderful applications. And I'm sitting here thinking about the how it's done. There are no projects like this happening in South Africa. People are not walking around with tablets in safe states. So, and for one, and I mean, is there any? Have you picked up any sort of stigma for these field workers, especially when you're coming back for secondary cases?
So yeah, that's a great question. I'll start with, I think, the first one on the safety side. We haven't operated in South Africa. We've operated a lot in Zambia, which is typically very safe. There's parts of Nigeria that we've operated in that are a lot more dangerous, but less on, I guess, like a tablet specific side, and more maybe in terms of stigma, or people just being unhappy that you seem to be there with tablets. What are they doing? That sort of information. So there is a lot of sensitization that goes into this, especially the very first time it's used in a given area. The diseases that we've used it for thus far have not had stigma or strong stigma attached to them, I should say. There's always questions around it, but usually the sensitization that we're doing takes care of that. If you were to use it for HIV or other diseases that do have that stigma attached, I think there's kind of the multi-steps that would need to go in that. Some would need to be some level of community level sensitization, but also in terms of data you're collecting, you should never be able to visualize that data at such a granular level on these public dashboards. And I think the program would just need to have conversations around, are we even able to visualize that privately, or the minute the data gets uploaded, is it masked immediately so that nobody has access to that level? Lots of open questions around like the geospatial ethics of it that we're kind of actively answering as we go. It's another really good reason why we do have an LC partner, which is the ethics, legal, and social implications of DSI Africa that we work directly with. And so as these come up, we're not just asking, our program partners, the researchers, and communities, we're also considering them.
Thank you for your great talk. I'm actually excited about your collaboration with WorkBeep because I'm a student from WorkBeep. I'm here on an exchange program for my master's research, and also with your collaboration with the government of Nigeria, because I'm Nigerian originally, and I worked for about 18 months with pastoralists. So I want to know, how well has your platform been used for animal diseases? And then I have a friend also from South Sudan who would like to use your platform for to monitor animal diseases because the country is facing challenges with regards to climate change and civil war. So I want to know if you provide workshops or trainings for interested members of the public on how to use your platform.
And you specifically said animal-based diseases. Did I get that right?
Yeah.
So yeah, in both Ghana and Nigeria, we're looking, especially in Ghana, we're looking specifically at vector-borne diseases, malaria, and thinking through how we can use it in other ways. We don't have any specific use cases yet, but we're only just having those conversations with the Ghana Health Service, both at the district level, and we're working up in Negrongo in the Upper East. And so they're using it for malaria, but there's discussions on how we'll continue to use it. Nigeria, we're also in a similar stage where we're just having those conversations and trainings with the various organizations. So I don't have any specific use cases yet for you there. But kind of as that segues into the next part of your question, we just had a virtual training, and we'll continue to have webinars, and we're looking for specific funding to actually begin doing further trainings in Nigeria, and creating more of a pipeline there between researchers and government on how to use both the tool itself as well as geospatial technology generally in order to answer some of these questions. And we're hoping that we're going to be able to take that other countries as well. It's kind of like we're working together to figure out where funding is, who can support what. We as Akros, to be clear, we've helped develop this technology and we're the stewards of it, but it is an open source platform. So our role is really to do the trainings and help people understand it and implement it, but that the level of ownership should be sitting within those programs and within governments eventually. That's the end goal.
Thank you, Christina. Really excellent presentation. My question is about, sometimes you kind of watch these demos and you think it's amazing, and then when it comes to the crunch to you kind of doing it yourself and getting the data sets and using the tool, sometimes takes a bit longer. So I'm just wondering, if you're coming to this cold and you want to use the field platform, and say you've got a population of 100,000 people, 10,000 households,
Oh, sorry.
Rika, if you wanted, I'll try here. I'm saying if you're coming into this, maybe I'll come and stand here.
Awesome, great.
So if you're coming to this cold, I'm just wondering about the setup time. So if you take an example of a population in South Africa, 100,000 people, maybe 10,000 households, you've got a whole lot of questionnaires you need to administer. You want to use the platform. So coming in from the outside, how much setup will that require? Or much of those data sets will be in there, or do you have to do a lot of work trying to get additional data sets? I'm just trying to understand what it would be like to actually implement this from start to finish.
That is an excellent question. And I'm happy to be answering it in 2025 instead of 2019. It used to take a really long time, to get all of the geospatial information in there, such as the enumerated households, etc. Now, much of that is, if it's not already in tool, right now we stream population level information from PopX, unless you have another data source for your population that you want to use. For the structures, what we're usually doing, you came to me today, say we're working in this area in South Africa, would be to look at the available information both on OpenStreetMap as well as through Grid 3 and Data Exchange for South Africa. And we're usually, and you can, there are Google footprints, building footprints available as well. So we usually just do a quick review of all of that to find the most complete one, and that can be pulled in within a day. So as far as the geospatial files are concerned, let's say 24 hours to get that loaded in and that instance spun up for South Africa. As long as you have access to the data that you need for your overlays, then that would be immediate, but that's often a big question, is getting access to that data either through the government or whatever source owns it. On the reveal side, the only thing right now that takes a bit more time is the configuration of the tool specifically for whatever survey or intervention that you're doing, but that also can usually be done within a day or so. It's usually just changing some of the form questions, and that's something that right now we need to do. We're working to make that configurable so that you could be able to log into the form, type in doing a structure level versus individual level intervention, and then configure all of that yourself. We're working towards that. That would take us probably a day to 5 days, depending on how complex it is. So I would say, I'll say a week if we have everything we need and can do that configuration quickly. Can be a lot longer, particularly if you don't have access to the information, or if new development needs to get done for such an intervention. That's a lot less likely as well, because we have different types of interventions that are already built into the tool. So a week, and then maybe up to 2 to 4 weeks. Thing that would take the longest is if you would need specific access to data sets that you don't readily have.
Thanks. Maya?
Yeah, we had close to 100 people online. I think that we have some questions online. So just 2 people online, you can put your hands on if you want to have a question online. Just one question from me, Christina. So when you increase the intervention of both the BADNet and the mass drug administration that you give that went close to 100%, what was the impact on new malaria cases and diagnosis and deaths?
That is a great question. So the intervention coverage increased up to 100%. We could show that, and we were able to show, based on the community level protection, that I think cases generally in the communities that were surveyed after that went down by about 15%. This was also like, it was just kind of on the heels of that, and so the case management in that area dropped off dramatically at that point because of supply chain interruptions and different things. So it was just for a really short period of time. So I say, like, the number is 15%, but it's a bit tricky to distill between all of the other confounding factors. But that's what we saw specifically in that area. We've seen in other studies that have, in other areas, reveal that usually you're able to increase your intervention coverage, often increase between 30 to 40%, and usually equates to a 5 to 10% reduction in malaria cases. But to be honest with you, that's based on real data, but we don't have a lot of studies that have actually looked at that. So it's just a handful that would have been back between 2019 to 2020, 21.
And another quick question, because a few weeks ago we had this brilliant talk. Stefan, the guy from Heidelberg? Yeah. That what he did, they start developing AI algorithms that could do pattern recognition. So, for example, they would put on top of satellite data. In that case, they were interested on dengue susceptibility and outbreaks in Rio de Janeiro. To try to map like areas. For example, he was very interested on water storage. But what he did, what was interesting on that he trained these algorithms to detect a given structure, and then he applied it again, and he got a much better accuracy. So, for example, imagine you have a household satellite map that you identify extra bounded structures, and then he trained that on the ones that he missed by going field, and he put that again and got a much higher accuracy. Is that something that you're already building across the use of different AI methods for pattern recognition to try to get more information from that?
So we haven't ourselves, but we've worked with partners that are doing that. In terms of, I think some of it is the remote sensing of those structures generally, and then country by country, the structures are made of different materials. We give them our information, that field verified information, for them to retrain some of their models. We haven't worked with anyone using AI specifically. It's just been model building kind of before that level. So we've worked with WorldPop on some of that. On the AI side, not necessarily on the pattern recognition, we're exploring building generative AI into the tool that really just helps with decision making at both that lower level and looks at insights based on the dashboard. We'll prompt field workers or field supervisors based on data that's coming in to kind of make their jobs easier for them, so they're not going through and reviewing everything all the time. But on the pattern recognition side, we haven't done anything ourselves yet.
Okay, thank you. So I'm going to give it back to the chair.
Okay, so I think we've reached the end of questions. And so are there any online? No. Okay, so we will release you. Thank you very much for your wonderful talk. And are you going to be around for a little bit longer if anyone